PD-L1 is run now routinely on non-small cell lung cancers. But then when I see the patient in clinic, I'm thinking to myself, there's some other questions I want answered. I want to know if they have an EGFR, ALK, ROS, RET, BRAF, HER2, et cetera. And so I'm now routinely ordering next generation sequencing on advanced non-squamous non-small cell lung cancer or on light never smokers. I don't tend to order it on squamous non-small cell lung cancer because that isn't really rich with mutations or targetable mutations. And when I order next generation sequencing, I get a rich variety of information back. I get these targets. I find novel targets that I can then sometimes refer for clinical trials. I get a measure of mutational burden. And I can also see some genomic signatures like UV damage or like microsatellite instability. All of these things can be seen within an NGS panel. And I think there's a lot of movement towards that, towards just using an NGS panel. Now let's recognize each panel can be a little bit different. Most of us have one available, and it is rich with the most data and therefore has become our standard test. I, as the oncologist, order it. I know the stage of the patient, and so we've not sort of handed that off to our pathologist at this point. But what happens is I put the wheels in motion saying I need NGS, and then there's sometimes some discussion about the adequacy of the specimen and whether the tissue will work, or whether this is not going to happen, you need a new biopsy, or maybe a liquid biopsy to try to get this answer.
Yeah, so our approach is similar, but a little different in that for all of our non-small cell lung cancers, it's the pathologist who originally puts in the request for the large targeted NGS panel. Again, just to kind of as a matter of a turnaround time, this is something that all the oncologists agreed to and we're on board, and so this is a good plan to increase our efficiency. So we also are really favoring of using kind of one large NGS panel to look at all of the biomarkers that are available and get additional information like mutation burden and microsatellite instability. This can be all done with one test. However, most of the only limitation to that is most of our larger panels in most institutions, the turnaround time I think is not quite what a lot of the oncologists want. Ours is around 10 to 14 business days or so, and we kind of have come up with an agreement with the oncologist that will also run a smaller targeted panel just to get EGFR information sooner, and then we're also doing ALK FISH in addition to the large panel, even though both of those information we will eventually get on the large panel, but they want the information sooner. So that's also, the turnaround times kind of influence also what tests we order and, what people are looking for. We've changed how many times we're running tests now to also kind of accommodate this turnaround time issue. If you don't have your targeted therapy information, you're kind of sitting around and waiting, and the patients are waiting for treatment. So that's something we try to be considerate of well, and as a group figure out what's the best way to kind of balance these issues.
I mean, the turnaround time is really so important, right? And, and I definitely, we as oncologists, it's not just ordering, it's when does it get back? And there's definitely those periods where you're like, I can't believe I'm still waiting for this test. This patient has stage 4 lung cancer, I need to get going. Yeah. I mean, I've had instances where I've met the patient, I said, look, we're not going to wait anymore. You need chemotherapy. I ordered it. I consented it. She went over. She was like IV in, and then the result came back, and it was a rare EGFR mutation. And I ran over there, and I was like, wait, no, don't get the chemotherapy. I'm going to order you a pill. It'll be ready in a week. And she's like, okay. So we stopped the chemotherapy. She went home. She never got it. We just, took the IV out and she went home. And so, yes, that's the timing of oncology. Sometimes there are decisions that are made last minute, but you do your best to get all this data back. We don't trust NGS is going to do that well with ALK and ROS, so we're running ALK IHC and ROS IHC fusions. Sometimes are harder to get with an NGS panel, so we also have ALK and ROS IHC with PD-L1 IHC and an NGS panel as sort of our group of tests.